We've got Helen Wright, who is the Eye Health Coordinator. We've got Prasad and Byron Klein, who are the optometrists working with Lines Outback Vision. They'll sort of, as visiting and resident optometrists, they will share their experiences in enhancing eye health outcomes for people living in rural and remote areas across WA. The presentation would highlight some of the collaborative efforts that Angus sort of touched on as well in regards to service delivery, resource allocation, training and integration of optometry and ophthalmology services, with some brief case studies as well, I assume that you've got to share as well. So if you could please welcome them.
Hi everybody, my name's Raj. I'm one of the optometrists at Lines Outback Vision. I've got Helen here, who is our Visiting Optometry Scheme coordinator, and Byron, another great optometrist working in partnership with Lines Outback Vision. I just again want to sort of acknowledge the traditional owners of this land that we walk peacefully on. Want to really be graceful to the Noongar and Whadjuk people sort of with us and also sort of teaching us along the way. And so, yeah, I'll probably very quickly hand it over to Helen, but yeah, this is a little bit of what we do on the title screen, working with Lines Outback Vision and with subspecialty ophthalmology, but we are the sort of busybodies at the pointy end, sort of making sure that there's a lovely heavy flow going through.
Okay. Where's the screen that shows me what I'm supposed to say?
Oh, that's true. Let me go.
There's supposed to be a screen which tells me what I'm supposed to say. Maybe. So this is 2006, in the beginning when I came on board. This is the picture of eye health services available in the across the north of the state. All of the green dots that you can see were visiting ophthalmology services, and there were at the time in 2006 one optometrist in Broome, one in Headland and one in Karratha, and nothing in between. Every so often a visiting optometrist would come from Darwin to Kununurra. So there were enormous gaps in the availability of eye health services across West Australia. We have to remember that optometry in Australia is a commercial model, and it's funded by the Commonwealth Government, and people make money by selling glasses. So in areas that you can see, this big tract between Wyndham and Karratha through the desert, it was an eye health care desert because there was nobody who could afford to either provide glasses or provide visiting services. So what happened was, if anyone couldn't see, they went to the doctor. The doctor said, "Oh, here you go. We'll refer you to the visiting eye service team." The eyes and would go on a big pile. The eye doctor would come along, the ophthalmology team, go up to one of these green dots, and the people 3 years later would be called up and would see the ophthalmologist and need glasses. So it was a very, very inefficient and very expensive system. So enter Margie. How do we move this one? Enter Margie. So in 2006, about the time there was the National Indigenous Eye Health Survey, Margie, who was an optometrist you saw in Angus's slide, came on a holiday to visit a friend who was in Balgo Hall, which is south of Halls Creek. They said, "Oh my goodness, there's no eye health services out here at all for anybody. Can you give somebody some glasses? Can you just do something?" So for the next 2 years, she worked out of the back of her car, providing glasses for people and optometry services, and she Medicare billed them herself. That was unsustainable, and so in 2008, the VOS scheme started, and the VOS scheme was, with the Indigenous Eye Health Survey, they realised that there was these vast tracts of desert. The government decided to do something and they expanded the VOS program, and so we got the contract to provide services to all these pink dots. So straight away you went from just the green dots to the green and the pink dots. Again, when we first started, there was almost no equipment in any of the clinics, so people would go out with a suitcase full of gear and and a trial frame and a few bits and bobs and provide the services as best you could and try and coordinate and link in to the green dots, which was ophthalmology, as efficiently as possible. And then with that efficiency, it became there was a need for coordination, and so WACS came on board and they provided funding for a coordinator, which was me. And so I've been with the program since 2009, and I've seen it grow from nearly nothing to where we're at now. This one. Oops. So these pictures here. So when we provided, with Margie, we decided to try and provide an eye health program, and we were very lucky because there was actually nothing, which means you've got a clean slate to start with. So you have to say, well, to design a good program, what are you going to do? And we looked at access, cost, distance, cultural safety, how people navigate the system, and good equipment and record keeping. So we set up a database, and the database was able to track people from wherever they went. We're working with highly transient people, so they might as well turn up in Columbaroo or Willoona or Kalgoorlie. All across the state, the same people are turning up. So we had one data system which was able to track people wherever they went and follow their eye health journey. And we tried to do cultural safety by working out of the AMSs, out of all the clinics in the communities. And we provided glasses with cost certainty or free of charge as far as we could. And that was what we did for the first the first 4 or 5 years. And then Margie decided to take a step back, and Lions Outback Vision's formed. So Lions Outback Vision started in 2013, and it was a sort of a marriage between ophthalmology and optometry. So instead of working as separate services, optometry on one side and ophthalmology on the other, we decided to come together to work as one team. So we had a shared record system. So the optometry, all of the optometry records of all the people who've been out on the front line, the foot soldiers, the GPs of health, I call them. I say the optometrists are the GPs of eye health. They're going out and doing primary care, managing people, monitoring them, doing what's required at the coalface. They can then work with the ophthalmologists, but they're working on the same page as part of the same team. So there's the efficiency of working together at every stage. In 2016, Angus started the Vision Van, which gave us extra coordination. In 2016, we also managed to take our records system live so that we could work together at every level. And then we extended telehealth, which makes an enormous difference to the optometrists out in the field. In 2020, was the Broome, not 2019, there was the Broome Hub, which gave us extra support. And to 2025, who knows? It's a continuing journey. So this is where we're at now. All the red dots are optometry, where we provide a service out in the desert. So it hasn't changed much from the time when we started, but the linkages between those places and ophthalmology has improved no end. And the amount of glasses that we've been able to provide has improved no end. And the quality of care that we are able to provide at the point of service has improved no end. So when we started, there were mostly not slit lamps in the communities and in the clinics, so we were really doing the best we could. And now we have slit lamps in almost every single community, and we have access to retinal cameras in most of them. So the optometrist, when they travel out onto the country, they can really manage and monitor most things in situ, and then they have access to the ophthalmology team to make a phone call, to get support where required, so that they can then really manage people where they need to be for as long as they can. At the point where they need to be moved along through the system, we can usually make a phone call or a telehealth and try and refer them either into the Vision Van for diagnostic work or into clinic for surgery, as the case may be. Telehealth has probably been the biggest game changer from where we sit. This is some stats over time. So I haven't got a pointer, but basically it started at 0 in 2006 and grew to where you start to 1,200, 1,300 people seen a year by 2010. By 2013, you see a brief dip, and that's where Margie moved away and Lions Outback Vision started. And then beyond that, it sort of increased exponentially, or just increased steadily. Then you see the big gap for COVID, where everything stopped for a little while, and then it's taken off again. The top line is the number of patients seen, and then the second line down, the green one, is the number of Indigenous patients, and the third one down is the number of glasses. And the number of glasses is the one that we're all obviously interested in and want to track. And you can see that it's actually now past the number of patients seen. So a lot of people are repeat clients. They've lost their glasses. They need something. So we might not have seen them, but they've rung us up and said, oh, can you sort us out? Can you get us some glasses? And so they're going out, notwithstanding that we actually haven't seen them. So last year we did 3,000 pairs of glasses just that went out through our organisation. 2,700 patient consults. 2,400 of those were Aboriginal or Torres Strait Island patients. Across the years, what's really interesting is that this number of female to male hasn't changed. The ratio's always been 60-40. It's maybe varied 39-61, but it's been really solid. 80% to 90%, depending on the year, Aboriginal. Coming in average of 86-87% Aboriginal clients that we see. The efficiency of our clinics is basic attendance across, when you average out across the services, 10 patients a day are seen by one optometrist who dispenses, manages, refers, does everything. The proportion of people with diabetes that we've seen sits around 50%, so we're doing full eye checks on people who have diabetes and helping to manage their care through to ophthalmology. The proportion of people with diabetes has grown from 40% to 50% over the years that we've been working, which is probably a reflection of both the increasing number of people with diabetes but also the better catching. The key stat, I suppose, is that 15 to 20% of people are referred on to ophthalmology, depending how you measure that stat, and which means that about 80% of people simply come to us because they want care, routine maintenance and glasses. So it's really important to, people get tied up with ophthalmology and how important ophthalmology is, but optometry is really the coalface, it's the primary health, and it really deals with an awful lot of people and their needs. So this is the coalface. This is how we send glasses out. The glasses come in, they get sorted, and they get sent to communities. Most of the glasses go to the local clinic, which is who we work through, who we partner with. And so they come in, they're sorted, they're boxed, and they go out express post to try and get them as fast as they can, but there's still a delay to the patients at the end of their journey. And this is what makes us do it, what makes us keep coming back for more, is everybody everywhere says, we love optometry, the patients all want to come and see you, and the joy when somebody goes, I can see, is really tangible. Lots of the artists especially. I'm gratified every time I see a picture of an artist from the Kimberley. They're all wearing one of our pairs of glasses. So then we talk to, if we've talked about glasses, and then it's the referral pathway. It's that other 16% of people. So shamelessly borrowing from the Indigenous Eye Health Unit leaky pipe that we're all familiar with. We've got the journey, which we all know, which we all recognise, where people there's this long and convoluted journey. People come in through the system and they go out or they get lost, and the key concern is that the people get lost. I think they fall out of the system and then they start again. And the starting again takes up an awful lot of time and energy. So what we're trying to do is to work with ophthalmology to reduce that leaky pipe. And here's an example of telehealth. So we've got a chap, he's been to see the ophthalmologist, he's been to see the doctor, he's been to see us all, and he's presented the other day in Fitzroy Crossing. He said, where's my surgery? I want to see the doctor. And we said, well, we were able to look up his notes. We were able to see that he'd missed an ophthalmology appointment. He'd been referred a long time ago. He'd missed his appointment. And so he'd been listed for surgery. He hadn't turned up. So we were able to say, you don't need to go right back to the beginning. We need to sort you out at this point in your journey. And so we rang the ophthalmologist. There you go. There's an example of telehealth. Hey, can I call you? Call you in 5 minutes. Yeah, call back, please. And then we've got this chap sitting in this waiting room talking on the mobile phone, and he's consented for cataract surgery. So then that wait list now is done. Oh, he's now waitlisted. The MR20's done. And he's now put on the list to see surgery. And if we hadn't managed to do that to streamline his care, he would have gone back into the queue, back to see an ophthalmologist, missed the appointment, and the whole thing would have been delayed a whole lot further down the line. And each time there's a transfer, people don't realise it's not just like in the city where you turn up to an appointment. There's usually a PATS coordinator. There's somebody going finding people. There's a whole lot of money spent. You know, you've got a whole team of people just getting people to an appointment. And if that appointment isn't really necessary, it's really good to be able to bypass it. So that's where we hope we are now. We sort of, instead of having this really curved pipe, we've got a slightly wonky pipe, which is just trying to straighten it out a little bit and keep people in that system a whole lot longer. So, yeah, when we started, we didn't have much equipment, and now I think Raj wants to talk about equipment.
I really only had really tiny stuff to say, but I'm sure many of you people would be aware of the provision of eye health equipment across Australia, both for diabetic retinal screening cameras, but most importantly, just the bare basic equipment like a slit lamp. I think over the opportunities that I've had over the last couple of years, it's just some key quotes that sort of come over and over again. Angus has said it in the past that sort of going to the regions shouldn't be second-rate equipment or second-rate care in any way. You're pretty used to sort of turning up to clinic and seeing something a little bit rusty and old and going, like, they probably lived 10 years of their life in a metro practice and then moved over to a regional sort of spot. But some of the equipment that we've got in a lot of the sort of Aboriginal medical service and ACHOs have been great, to the point where a lovely student sort of a couple of weeks ago said, that slit lamp is far better than I've ever used anywhere else in the state. I could do far better eye care with that thing. And we were in the Dampier Peninsula in Lombardina, quite a few 100 kilometres away from Broome, and yeah, it's been really, really good. As Helen was sort of telling me, that it's been a lot of hard work over the years, a lot of the cost involved is some service contracts, but we've been able to streamline that by be able to building that ourselves and maintaining it ourselves and being pragmatic about it as well.
It just dawned on me with Raj saying that Wirrkimaya, the Aboriginal Medical Service in Headland, was actually the first optometry clinic in Headland to have an OCT in its entirety of Port Hedland. So it's quite remarkable for a town of 16,000 people that that we finally had an OCT there. So it's remarkable for that kind of gear to be in an Aboriginal Medical Service where the town doesn't even have one aside from the hospital. So yeah. It's remarkable.
Yeah, so we've been, as our program has been the coalface of all of the rollouts of equipment through West Australia. We first of all, we were the diabetic retinal cameras rollout. It wasn't our choice to get the cameras that were rolled out, but we did the best we could with the equipment that was provided. And all the time when they were rolling out the retinal cameras, we were saying, please, 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 could we have slit lamps? And our prayers were answered, and 2 or 3 years later there was the national rollout of slit lamps, and that was a real game changer where we were concerned, because it really, really made a difference to the quality of care that we could provide on country to people, and where before you would have had to refer someone to be seen somewhere where there was a slit lamp, you could keep people on country and just be much more sure of your diagnosis and the journey that patient had to go on. How do we go backwards? That one. So another case study was this lovely lady who was very happy for us to share her story, Mari from Balgo. She's one of our very first patients. Margie saw her in 2006, so we've been seeing her for now nearly 18 years, same service, same patient. For many, many years she was absolutely fine. She would just come in for an annual checkup because she has diabetes. And then gradually through around 2016, 2017, her vision started to get a bit worse. And she was really very, very reticent to have cataract surgery. Stephen sort of gently nursed her along. And in the end, she still didn't want to have cataract surgery, though her vision got down to, I think it was about 6:36. She wasn't seeing well at all. It was impacting on her painting. And then Angus had a blitz. And so a blitz is where, instead of going through the normal pathway to eye surgery where you just go on the wait list, we say, okay, we're going to target an area like Balgo or Jigalong or the Nunajara lands, and we're going to try and get a whole bunch of people who all require similar surgery, fly them in on a plane and do a blitz. And the blitz is a really popular way of from the patient's perspective, they really enjoy it. So Murray came on a blitz, and she got on the table. She had one surgery done. And then Angus said, well, what about the other one while you're at it? Because you need 2 eyes done. So we did the second eye. The next day she came out, she said, I can see. She was so happy. And then we went back out to community. We followed her up in community. She's now getting glasses and annual checks from diabetes. And with one service, I think she's had living in Balgo, which is sort of at the top of the Tanami Desert. It's a pretty amazing journey that this lady can have that she certainly couldn't have had 20 years ago. What have we got now? And that's where she's at now. She's got glasses and retinal monitoring. I think that's it. Is that it? No, what one else? Did you want to talk about the future?
Yeah, so I've sort of talked about sort of the differences between metro and regional and not being sort of second-rate care at all. And we sort of have the challenges fairly similar when you sort of move between regions, especially moving away from somewhere like Sydney, Melbourne, or sort of Perth. There are sort of rates of refractive error everywhere, but the rates are sort of just sort of different in frame of mind when you sort of look at each of these challenges over the way. So we should really be united in terms of making sure that there isn't a divide at all within that care that we provide, not just to rural regional, but to everyone overall. Oh, yeah.
So I went off piece there about the SET, but it was just a fun fact that I hadn't considered in Headland. So yeah, as Raj said before, I'm an independent optometrist in Headland and work with Lines Outback Vision at the Aboriginal Medical Service Maya on a nearly weekly basis, and have done for nearly the last 3 years, and support the ophthalmology team who visit Headland on a monthly basis as well. So I just wanted to share my experience in working with Lines Outback Vision and the system as it stands. So no system's perfect, but I've in my short career had a bit of experience in other primary healthcare systems, whether it be private or even public systems. And this system is exceptionally good and efficient. The main reasons being is the unsung heroes of the administration support. So Helen as the coordinator, but as well as the other LOV administrators and support workers, whether it be purely admin or doctors and other optometrists. It makes sure that people are seen at clinics, the clinics happen in the right place and time, that the supply of glasses and magnifiers supplied, and that you can really focus on your job of being an optometrist. You're not worried about, can this person afford their glasses? You go, look, here are your glasses, bang, done. And it's a real privilege to be able to do that. So coupled with the ophthalmology support with ad hoc telehealth clinics, as well as just streamlining referrals and consent for surgeries or support for challenging cases. The Vision Van is also a fantastic service where, for cases that are not as urgent to, know they're going to be seen in the next few months. And it makes you feel confident that patients that you're seeing are not going to fall through the cracks or through the leaky pipe, that they will be seen and their problems will be resolved. So touching on the shared software as well with ophthalmology and optometry, it's really another really powerful thing that you can access people's data from ophthalmology and optometry, depending on the clinic, because you're not having to reinvent the wheel, search for information, make phone calls. It's all there in front of you, and you can make good decisions. And along with that, working out of Maya is a real privilege, and I've got Skip and Tanya here, chronic health disease coordinators, and they play a huge role in making sure people come to the clinic. And slowly, like we started out on the Tuesday mornings, only seeing maybe 2 or 3 people initially, and now we're consistently seeing 5 or 6 people to 7 people some mornings, as well as the drivers, nurses, administration again, and the doctors. At the end of a session, you can feel really confident that people are being well looked after, and it makes it a whole lot more rewarding and enjoyable. So yeah, I look forward to continuing the work with Maya and Lines Outback Vision. It's great. Thank you.